Hello everyone, my name is Kanfam and today I would like to tell you about fetal monitoring and fetal well-being. In the fetal monitoring part, I would like to talk about the purpose, the baseline fetal heart rate, the fetal heart rate variability, accelerations, decelerations, and contractions. So what is the purpose of fetal heart rate monitoring? That will help detect changes in the normal heart rate pattern during the labor. If certain changes are detected, steps can be taken to help treat the underlying problem. It also helps prevent treatments that are not needed. A normal fetal heart rate can reassure both mother and the healthcare provider that it is safe to continue labor if no other problems are present. So what is baseline fetal heart rate? It is between 110 to 160 beats per minute for at least 2 minutes period. It is recorded on the upper grid of the paper strip and is expressed at beats per minute. The uterine contraction pattern is recorded on the lower grid. The average fetal heart rate that occurs for at least 2 minutes during a 10-minute period and are average over 30 minutes. It is accessed while there are no uterine contraction. The next one is fetal heart rate variability. That's the fluctuation or constant changes in the baseline fetal heart rate above or below the baseline in a 10-minute window. The grid paper will review sawtooth appearance, reflection of intact central nervous system, and cardiac status of fetus. The first one is moderate variability. That's the changes of 6 to 25 beats per minute from the baseline fetal heart rate. It is desirable because it indicates good oxygenation of the central nervous system and fetal well-being. The marked variability occurs when there are more than 25 beats of fluctuation over the fetal heart rate baseline. It can indicate cord prolapse or maternal hypotension. The absent variability. It is less than 6 beats per minute change from baseline for a 10 minutes period, and it is typically caused by uteroplacental insufficiency or maternal hypotension, cord compression, and fetal hypoxia. In that, in that situation, you can position the mother on her side, increase regular IV fluid flow rate to improve the maternal circulation, administer oxygen at 8 to 10 liters per minute by mask, and notify the healthcare provider. For episodic changes, that's the change in the baseline fetal heart rate, but not associated with uterine contraction. They are brief and quickly return to the baseline. The periodic changes. It is associated with uterine contraction that quickly return to the baseline. It includes acceleration and any three decelerations. So what is acceleration? It is temporary abrupt rate increase of at least 15 beats per minute above the baseline fetal heart rate that lasts 15 seconds but less than 2 minutes from onset to return to baseline. The reflex fetus is well oxygenated, also known as reassuring pattern. It occurs with fetal movement and the basis for interpretation of the non-stratus. The prolonged acceleration equal 2 to 10 minutes longer than 10 may be considered a change in baseline fetal heart rate. So why does it happen? First reason is spontaneous. It's usually reassuring sign associated with fetal well-being, may suggest fetal movement, responsiveness, and alertness. The second one is uniform. It's most often a response to uterine cord compression. This can be the start of a cause for concern or maybe a normal part of the laboring experiences as the fetus progresses through the birth canal. The deceleration. There are 7 types of it. The first one is called early decelerations. It is temporary gradual rates decrease during contractions no more than 40 beats per minute below baseline. Always return to the baseline by the end of the contraction. It will show U-shaped pattern. that begins early with a uterine contraction and ends near the end of the contraction. The cause of it is compression of the fetal head and is a reassuring sign of fetal well-being. Variable deceleration. A rapid decrease of 15 beats per minute below baseline lasting 15 seconds to 2 minutes. Do not always exhibit a consistent pattern in relation to contraction. It can be look like V for variable, W or U shape. It may be caused by cord compression. For the late deceleration, it looks similar to early decelerations, except that they begin after the contraction ends. It suggests that placenta is not delivering enough oxygen to the fetus. It's called uteroplacental insufficiency or non-reassuring pattern. The late decelerations under 15 beats per minute below baseline are a central nervous system response to fetal hypoxia. The prolonged deceleration, that's the abrupt fetal heart rate decreases of at least 15 beats per minute from baseline that lasts longer than 2 minutes but less than 10 minutes. Fetal heart rate may drop to 19 beats per minute during the 2 to 10 minutes period. It is caused by cord compression or prolapse, maternal supine hypotension, or regional anesthesia. If it's longer than 10 minutes, it may be considered a change in the baseline rate. The next one is recurrent. It occurs in more than 50% of uterine contractions in a 20 minutes period. The intermittent decelerations occur in less than 50% of uterine contractions in a 20 minutes period. The last one is sinusoidal pattern. It's the specific fetal heart rate pattern that has a smooth wave-like pattern that recurs every 3 to 5 minutes and persists for 20 minutes or more. It is caused by fetal response to medication provided to the mother in labor, such as Demerol or Stato or fetus who is anemic. About a contraction. So I would like to talk about the characteristic first. So you have to ask about the frequency. They are time from the beginning of contraction to the beginning of the next contraction. The regularity, the duration, start from the beginning to the end, the intensity of the contraction, palpation or mild or moderate or strong. And of course, patient will describe it for you, so it's very subjective. So when you do assessment, for palpation, you will use the fingertips to palpate the fundus of the uterus. For the mild, uterus can be indented with gentle pressure at peak of the contraction. Moderate, uterus can be indented with firm pressure at peak of contraction. For the strong one, uterus feels firm and cannot be indented during peak of contraction. So what is the segments of contraction? The first one is increment, that's the beginning, building of the pressure. Next one is acme, that's the most intense part of the contraction. The next one is decrement, the diminishing of the contraction. And the last one is the called rest, the period of time between contraction. And last one, the Braxton Hicks contraction. It is irregular, usually mild uterine contraction that occurs throughout pregnancy and becomes stronger in the last trimester. So what is the nursing role in this process? You have to assess fetal heart rate pattern, implement appropriate nursing interventions, report non-reassuring fetal heart rate pattern to healthcare provider, and you have to document accurately following the standards of care. No CNA LPN allowed to do this process. You can do that with the doctor and the healthcare provider. The next one is fetal well-being. In this one, I would like to talk about some tests to check the fetal well-being. It will include amniocentesis, fetal lung maturity, LS ratio, contraction stress test, also called oxytocin challenges test, non-stress test, and biophysical profile. First one, amniocentesis. What will you do with that? The aspiration of amniotic fluid for analysis by insertion of a needle transabdominally into a client uterus and amniotic sac under ultrasound guidance, locating the placenta and determining the position of the fetus after 14 weeks of gestation, withdrawal of 15 to 20 milliliter of fluid. Fluid is shielded from the light to prevent breakdown of bilirubin. Fetal and maternal vital signs will be monitored, and the ROH-GAM given to the Rh negative mother. So with this one, there are two risks, one for maternal, one for fetal. So for maternal, it will be hemorrhage, fetal maternal hemorrhage, infection, contractions, labor, eruption of placenta, damage to intestinal bladder, and the amniotic fluid embolism. For fetuses, it will include death, hemorrhage, infection, direct injury from the needle, miscarriage, and preterm leakage of the amniotic fluid. The next test is fetal lung maturity. That is a test of fetal amniotic fluid to assess for fetal lung immaturity. LS is the abbreviation for lecithin and sphygmomyelin, the two components of surfactant in amniotic fluid. From 30 to 32 weeks, L will equal to S, so the ratio is equal 1. More than 35 weeks, L will higher than S, so the ratio is 2/1. It will be respiratory distress unlikely. The next one is contraction stress test, also called oxytocin challenges test. So the nipple stimulation for 2 minutes to release the oxytocin to begin contraction. If nipple stimulation does not work, low dose of pitocin will be administered to induce the uterine contraction. The positive result, you will see abnormal findings indicated with persistent and consistent late deceleration on more than half of the contractions, such as the uteroplacental insufficiency. Variable deceleration may indicate cord compression, and early decelerations may indicate fetal head compression. If the result is negative, you will see normal finding. There are no decelerations within a 10-minute period of 3 uterine contractions. The next one is non-stress test. That is the technique used for antepartum evaluation of fetal well-being performed in the third trimester. If it is reactive, the fetal heart rate is a normal baseline rate with moderate variability, accelerates to 15 beats per minute for at least 15 seconds and occurs 2 or more times in a 20-minute period. Non-reactive fetal heart rate does not accelerate adequately with fetal movement and continue to a contraction stress test. What is the indication for non-stress test? Decreased fetal movement, post-maturity, IUGR, digestional diabetes, hypertension, historic of previous fetal demise, advanced maternal age, sickle cell disease, gestational hypertension, isoimmunization. Last but not least, biophysical profile. It uses a real-time ultrasound to visualize physical and physiological characteristics of the fetus and observes for fetal biophysical response to stimuli. Test for fetal heart rate, reactive non-stress test equal to fetal muscle tone, fetal breathing pattern, and amount of amniotic fluid. The total score of 8 to 10 is normal, 4 to 6 is abnormal, and suspect chronic fetal aphasia. If it's less than 4, it's abnormal, strongly suspect chronic fetal asphyxia. So I use this reference for my presentation today. Some diagnosis, you can see it when you read it, and it describes everything in it. And thank you for your listening.